A friend of mine showed me this strip and was wondering about the configuration of P wave and how to differentiate it between the sinus origin with non-sinus origin pacemaker cells. As we know, EKG is a recording of cardiac electrical activity from different angles. So it is very important when you assessing the strip, you know a strip recorded by which leads. If you look at this cycle, at beginning, it will be very difficult to have a correct interpretation unless you notice the electrode, the recording electrode is in lead AVR. But if I tell you this cycle recorded by lead 1, I'm sure you will report an abnormal finding. The presentation of the EKG component and their access is acceptable for lead AVR, but absolutely wrong for lead 1 because this is the configuration of the component and also access of the EKG for lead 1. Based on this summary, let's check our strip. So we are interpreting an strip with which recorded by lead V1. This electrode should be located in the right side of the chest, fourth intercostal space, and in parasternal line. In our strip, there are a couple of the cardiac cycle with different timeline rhythmicity. Based on definition, P wave is a first deflection from isoelectric line, which normally located before a spiky QRS complex. So this is my P wave, this is my P wave, this is my P wave, and also this is another P wave. If I'm gonna make a larger picture of one of these one, consider again, this is my P wave, QRS, and T wave, and consider this one as an isoelectric line. As you see, P wave has two phases. Initial part of the P wave is located above the isoelectric line, and the terminal part of the P wave is located under the isoelectric line. This configuration called biphasic P wave, which is the normal presentation of sinus P wave. Now let's see what is the mechanism and why the axis of P sinus P in lead V1 is biphasic or bidirectional. Why sinus P wave is normally biphasic in lead V1? During the assessment of the EKG, what it comes to your mind when you see the P wave? What event should be done to see the P wave on EKG? On the other hand, what are the requirements of generation of the P wave on EKG strip? Presence of the P wave on EKG strip require two important events. The first event or first requirement, it should be an electrical signal inside the atrial tissue from any source. The origin of the electrical signal can be from SA node, it can be from atrial tissue, it can be from AV node, or it can be from his Purkinje network. At this point, I don't focus on the origin of the electrical signal. The second requirement, moving or conduction of electrical signal through the atrial tissue and depolarize them. Depolarization of atrial tissue can be detected, the P wave can be detected presence of the P wave on the EKG. In this picture, a small area of the atrial tissue is depolarized and causes a small positive deflection from isoelectric line, which shows the beginning of the P wave. In normal condition, SA node generate an electrical signal transmitted to the right atrium, start to depolarization of the right atrium immediately through the internodal pathway and cell-to-cell direction, which are not shown in this picture. The P wave represent depolarization of the right and left atria both together. At this point, depolarization is limited just to the right atria. But how about left atrium? Electrical signal can transmit to the very special conduction pathway toward the left atrium. Depolarization of the right atria is in progress while transmit of the signal continues toward the left atrium. When the electrical signal reach to the superior part of the left atria, partial part of the right atrium is already depolarized. As a result, makes bigger deflection of the P wave from isoelectric line. By entering the electrical signal to the left atrial, these chambers start to depolarize as well with delay in compare with the right side. Let me stress one more time the reason. Electrical impulse released to the right atrium directly and start to depolarization immediately. But electrical impulse has to move by Bachmann fibers through the superior part of the atrial tissue toward the left atrium, which of course takes time and reason for delay in depolarization in the left side. Now, both right and left atria are in depolarization phase. When more than 50% of the right atria in depolarized, potential difference in atrial membrane decrease, and as a result causes lower the deflection toward the isoelectric line. But continuous depolarization in the left atria can be detected by another positive deflection from the isoelectric line. The second deflection is related to the depolarization of the left atrial tissue. Progression of depolarization in the left atrial can increase amplitude of the second deflection. This process continues till both atrial tissue become depolarized and deflection back to the isoelectric line. As we notice, because of delay in left atrial depolarization, atrial tissue has non-simultaneous depolarization and cause separation in atrial depolarization. As a result, P wave consists of two components. The first component, called P1, which related to depolarization of the right atrium, and the second component, called P2 component, which related to depolarization of the left atrial. If we go back to our strip, now we have a P wave with two components. The initial component is P1, which related to the right atrial, and terminal component is a negative, with P2 component is a negative, which related to the left atrial depolarization and located below the isoelectric line. Both components of the P wave can be seen in lead V1 because of the unique anatomic location of the V1. If you look at the wave by lead 2, these two can be overlapped to each other. Lead 2 actually shows one P wave because these two components have overlapped to each other. But because of the angle of the P1 lead 1 to the atrial depolarization can show separation between the right and left atrial depolarization. At beginning, I said P wave with sinus origin is biphasic in lead V1. And then I explained why it is biphasic and why it has consists of two components of the P1 and P2. Now I try to explain why two components of the P1 and P2 are detected in the opposite. Heart is located inside the chest between two lungs and behind the ribs, in the place which they call it middle mediastinum. Some anatomical characteristics of the heart have effect on the cardiac conduction system. For this reason, I like to mention them at this point. The heart is divided in two right and left parts. These two parts are not symmetrical anatomically, and also is not located 100% vertically. Location of the heart inside the chest cavity started from the top to the bottom, from the right to the left side, and from the back to the front. Also, I like to mention two axes of the heart. The transverse axis or short axis of the heart, which started from the right border continuously to the left border of the heart, and also long axis, which start from the top of the heart, superior part of the heart, and comes down up to the and pass through the inferior surface of the heart, which they call it long axis. The reason I'm bringing up, during embryologic period or intrauterine development phase, heart has rotation around his long axis. Because of this axis, actually, right side of the right atrium is located on the top and right side. Right ventricle comes to the anterior part behind the chest ribs. Left uh, ventricle can make part of the left border of the heart, but usually cause the majority of the inferior surface of the heart. As you see in this picture, left atrium can cause the posterior wall of the heart. For this reason, see, as you notice, the left heart, the left atrium and right atrium are not located in the same line or same level. For showing this one, actually, I like to take a transverse section from the heart, superior part of the heart, and look at the inside the heart while it is in the chest cavity. Now we are looking inside the chest cavity from the top. Since we see the vertebral column and also a spinal cord in this section, this part will be considered as a back or posterior wall of the chest. As a result, in the opposite direction, in the opposite side, we can find sternal bone or lower part of the monobrium sterni, with continuation of the anterior section of the ribs. As we know, the right side of the heart is made by the right atrium. So the right chamber will be considered as the right atrium. Also, please pay attention to this picture. The right ventricle is located in front and lower part of the right atria. Based on this, if we come here, we move to the anterior or lower part of the right atrium, we can find the right ventricle. We already accepted the rotation of the heart during embryologic period moves the right atrium to the right and inferior part of the left atrium. So from right atrium, if we move posteriorly and laterally, we can find the structure like left atrium. Of course, the remaining chamber will be considered as a left ventricle. Please be advised, by using this technique, you can also read and find the structures in CT scan or MRI as well. Since I saw this picture, a very important concept came to my mind, which will be useful to share. As you see in this picture, the esophagus is located directly behind the left atrium. This anatomic relationship can be beneficial in cardiology. Most likely, especially my friends in telemetry who have experience of calling the cardiology unit to notify them by losing the EKG wave or following disconnection, and healthcare staff responded, "Oh, patient went to TEE." What is TEE? What it stands for TEE? TEE stands for transesophageal echocardiography. During these tests, patient swallow the echocardiogram probe till to the mid part of the esophagus, and we can evaluate and find possible abnormality inside the left atrium. For instance, if you look at this picture, we send the echocardiography probe through the esophagus up to middle part of the esophagus, and because since this directly is located behind the left atrium, we can evaluate any abnormality inside the left atrium, like left atrial enlargement. Also, consider since left atrium is connected to the left ventricle through the mitral valve. Any abnormality in mitral valve also can be detected by echocardiogram TEE. For instance, mitral stenosis or mitral regurgitation. Also, please look at this picture. Also, since left atrium is located posteriorly and laterally to the right atrium, and these two chambers are separated by the interatrial septum, any abnormality in interatrial septum can be evaluated by TEE, for example, ASD, atrial septal defect. Long story short, let's go back to our conversation. The SA node is located in the upper part of the right atrium. SA node generates electrical impulse and discharge it directly to the right atrium. Release of electrical signal in the right atrium can cause depolarization of the right atrium, which can be detected by the lead V1. But where is the location of the lead V1 and how we can find this location? Please pay attention to this picture. In order to find the location of the lead V1, first we have to find the angle of the Ludwig. What is the angle of the Ludwig? Angle of the Ludwig actually is an anatomical marker in front and upper part of the chest. Please pay attention to this picture. External bone or external bone consists of three different bones which they are connected to each other. On the upper part consists of the monobrachium sterni. In the middle part is the body of the external bone or external body, and in the lower part consists of the xiphoid process. Contact and junction of the external body with the monobrachium sternum can create bony prominence in front and upper part of the chest, which located at the same level with the second rib. By finding this angle, actually we find the second rib, and under it we can find the second intercostal space. Definitely, under the second intercostal space, we can find the third rib, and under the third rib, third intercostal space, fourth rib, and fourth intercostal space can be found. And here is the exactly the we have to put the lead V1, but which part of this space we can put it? If you pay attention to this picture again, the right border of the right heart is a little bit is passed through the right external border. As a result, lead V1 should be in the paraexternal line. Para means neighbor. It means next. So here is exactly the place we have to place the lead V1. If you come here, since this is the cross section of the monobrachium body or external body, and here is the right side or right external border, lead V1 exactly should be located here. We said the right atrium starts to depolarize. By activation of the right atrium, depolarization wave directed toward the right side, which can be detected by the lead V1, and also inferiorly toward the AV node. Moving of electrical signal toward the V1 can cause positive deflection from the isoelectric line. Also, if you remember, electrical signal from the SA node can be transmitted to the left atrial by the Bachmann fibers and activate the left atrium after depolarization of the right atrium. By activation of the left atrium, depolarization wave directly to the lateral or left side and also posteriorly. Since depolarization wave is directed away, is going opposite direction to the V1, is going away of the V1. Because of this movement cause negative deflection from the isoelectric line. Depolarization of the right atria can cause P1 component of the P wave, and depolarization of the left atria can cause P2 component of the P wave. Although activation of the both right and left atria are separate events, both in different time and different direction, still lead V1 can detect them because of the unique position of the lead V1 on the in the chest wall. The movement of the depolarization wave in opposite direction or different direction present them in the opposite deflection from the isoelectric line. As a result, in lead V1 we have biphasic P wave, which is very normal for P wave from sinus origin.